These are the top 5 updated testosterone facts from a doctor's perspective that I want to give you guys today. This is February of 2023, and I've revised these all the time for you guys to make sure that we stay on top of the new data and clinically integrated for what's relevant for men that are on testosterone. And of course, this is always going to be imperative for new men that are newbies on testosterone, because a lot of the stuff here, the doctor either hasn't told you explicitly or maybe is not aware of, because I spend my life 24/7 eating, sleeping, and pooping men on testosterone. So, number 1, let's talk about testicular atrophy. Did you know that when you start testosterone, I don't care if it's gel, injection, even pellet, sooner or later, your testicles are going to atrophy, even young men. But do you realize that the sex can be fabulous? Your balls shrink, but your sex is great and better. I've actually been so myopic on this because I've been on testosterone for so many decades that I've really lost sight on this, and that new men come to me and say, "Doc, this is crazy. My sex drive has never been better. It's insane, or it's as good as it used to be when I was a teenager or when I was in my 20s or maybe 30 something. But my testicles are completely shut off. But my sex is great." Here's what's happening, guys. When you replace testosterone exogenously, essentially it supplants your natural testosterone. Your brain goes to sleep to a greater extent. Testicles disconnect. We know this is the hypothalamus pituitary gonadal axis. It's proportional, definitely, to how much testosterone you're giving in the beginning, but at a certain point, even with TRT doses, even a little bit of testosterone, you're going to shut down your testicles. And if that's a problem for you, cosmetically or from a fertility standpoint, you want to be careful. But it is true that testicles are atrophied. Even for decades, the sexual experience can be unbelievable because it's in the central nervous system. I want to explain something to you guys. Other medicines, ancillary medicines that are used, let's talk about HCG used with testosterone. There's no real data for this, except for, of course, Dr. Lipschultz has looked at adding HCG for a very limited amount of time for newbie guys, not real hardcore steroid guys that are on testosterone, and then up to about a year maintains semen function, sperm function into a normal range. But after a year or so, guys, I can tell you, and depending on who you are and how much you keep up with it, it may or may not work. So again, these are warnings for you guys. If you want to maintain fertility, you're in an age, maybe late 20s or even 40s, where you want to be on testosterone and also be fertile. That's going to be a warning. There's going to be work to do. Now, HCG added to testosterone. Here's the trial. It's about 250 to 400. It's international units. It's 2 or 3 times a week. You could do it intermittently. You can go on, off. You have to consider the testosterone endogenously on top of exogenously. It's going to be high. Look at the free conversion to estrogen. This is just all my bottom line stuff when I prescribe HCG for men on TRT, for testicular atrophy, even to maintain fertility. It's very tricky. You got to understand that it's going to bump up your total cumulative dose of testosterone, and from anxiety, from brain, from puffiness and estrogenicity to the heart stuff, and from the ABCDs, there's going to be an effect. I think that most men, when you're on testosterone for life and you just submit to that, you find that great dose, and the sex can be great, but you're going to have to accept your testicles are going to be atrophied. It's just part of the deal. And so many men, they don't know that. That's why this is new facts, again, that I'm giving to you guys. Next, the anti-aging clinics are adding Gonadorelin, which is GnRH agonist, because they have problems getting HCG. I don't recommend that, guys. Again, there's no data for that. HCG's been in the streets for years. It works with testosterone. That's kind of old school stuff. A lot of data for that. And more important than real legitimate data, it's anecdotal data. It works. We know the limitations. We know how to use it. We know the doses, and we could accept the outcomes. Gonadorelin came into play because they couldn't get something, so they supplanted it. In my opinion, that's wrong. Be careful with Gonadorelin. Clomid, adding Clomid in place of HCG on testosterone, no. I see that also happening because these clinics can't get HCG. I just think no. I just don't agree with that SERM. It's used for fertility with HCG off testosterone. For some men, they can use N-clomiphene or clomiphene citrate, which is Clomid. They could use it by itself if they're kind of newbie guys and they're not on testosterone, but using it in place of HCG to maintain testicular atrophy, wrong. It just doesn't work well for me. And again, give the comments and come on the Anabolic Doc app and talk about this stuff because this is all I do 24/7. Next and last on this one point, which is testicular atrophy, fertility. If you want to maintain fertility, if you want to keep fertility, you're going to have to come off testosterone completely and then switch right over to different doses of HCG mainly, plus or minus Clomid. That's it. Come on the app for more detailed information. Number 2, gynecomastia. There's 2 types of gynecomastia, again, that a lot of guys are not going to be aware of this until they're on testosterone. Let's talk about the 2 types. One is a mass. You have a physical mass. The other type is called sensational. You have a sensation of gynecomastia. It's uncomfortable. It's painful. Now, when you have the mass, I've never seen one case of breast cancer. I'm going on over 20 years with thousands of patients. That is just a miracle to me. That with superphysiologic androgens, not to mention estrogen level, we don't see an uptick in breast cancer for men. If you look at breast cancer for men, if you Google this, you'll see 1% of breast cancer are men. But it definitely is not a risk inherently for androgens. Remember the history. We used to use drugs like Masteron for metastatic breast cancer for women. So this is very complex when you have this analog, antagonistic, very complex mechanisms where in some part of the body you have stimulatory effects on the receptors and you have agonistic receptor modulation. This is super complex, like tamoxifen. Okay, that's a breast cancer drug, right? It's selective estrogen receptor modulator. We think there's something going on with androgen levels that are much higher stimulation and saturation versus, in addition, at the same time, a comorbid increase with estrogen levels. Ultra-sensitive, if, as you know, estradiol. We just don't see that mass is gynecomastia mass. But if you have a mass and you come to any doctor, you're a man, they have to think it's cancer until proven otherwise. Please forgive us for that. You're going to go for a mammogram. Isn't that interesting? You're going to go for ultrasonography and MRIs potentially and biopsy. Guys, this is just what it is. So the mass, if you feel comfortable, if a physician or you feel comfortable that it's not cancer because it's just straight up gyno, then you have to make adjustments. Here's what you do. Just don't live on aromatase inhibitors. Modulate your testosterone. There's where the microdosing comes in, guys. Again, it's really true. If a doctor gives you 200 milligrams of cypionate per week, not to mention every 2 weeks, it's not going to be right, guys. We don't want to hate on the doctor. They just don't know this stuff, So you want to limit that conversion, that bolus conversion. That's why you microdose. Check ultra-sensitive estradiol. Don't check total estrogens because the lab assays, they become contaminated. So you'll look at this total estrogen that's wacky, and you're on more and more AIs because the lab is cross-reacting with some other reagent, and it's saying that you have high estrogen when you don't. Ultra-sensitive estradiol. I learned this about 10 years ago, and I learned this from the lab expert, PhD guys. They had to teach me that. Limit tamoxifen and raloxifene, selective estrogen receptor modulators. You could use it. I use it for short terms. This is more for the sensational. Doc, it's irritating. We're on the lowest dose of test. I have some sensational gynecomastia. It's irritating to me. The shirt hurts. You could use some of these drugs. You better be careful. There are risks, not to mention the estrogen, the brain, the emotional stuff, and there's risks for DVTs, right? right, guys? I mean, this is my ABCD stuff. There's risk. If you just Google tamoxifen, raloxifene, you're going to see, this is for women, right? These drugs. You're going to see there's a slight uptick for blood clots. Again, I've seen it. It's rare, guys. It's just gambling. You're just gambling. You're gambling in Vegas with this stuff. The last piece for the gyno, if you have a mass or you don't like it, consider seeing a great plastic surgeon that does the surgery. Not to mention for pro bodybuilders, there's a guy in New York, there's guys all over the country. All they do is male gynecomastia surgery. Might cost maybe $5 or $8 grand, depending on per nipple. If you're doing both sides, most guys want both. These guys are not general surgeons. These guys are plastic expert surgeons. You don't want a general surgeon. It looks like an ice cream scooper has scooped out under your nipples. It sucks in. It looks horrible. You have to get another surgeon to fix it, and then it's too late because they've removed too much tissue. See an expert. Number 3, prostate disease. Let's talk about 2 things: cancer versus BPH. And that's just the enlargement of the prostate. Cancer, number 1. This is evidence-based information that, again, doctors, unless they're studying this stuff, they just don't know. Testosterone and androgens from decades of data, most of it's obviously retrospective data, but there are a lot of meta-analyses, and there's a lot of good just evaluation by very smart urology doctors. One very interesting data piece is something called testosterone saturation model. This is Abraham Morgentaler. He's a Harvard urologist. You could go to Google, put in Morgentaler testosterone saturation, and just read. You'll see that the incidence, this is about 20 years ago, and it's been proven today by the best urologist, again, UCLA, Cleveland Clinic. The conservative urology doctors are not going to argue this. They're going to say testosterone replacement and exogenously doesn't cause prostate cancer, but if you have prostate cancer, it could worsen it. But for a man that's young, that's in his 30s or 40s, we know that for decades, looking at the data, he's actually at a lower incidence of aggressive malignancy of the prostate. Guys, lower. It's somehow protective. And again, fact check this. Fact check it. If your doctor doesn't know that, doesn't mean you're not monitoring your PSA and your prostate. And I'm going to talk about that in a minute here more. It just means that the data, you can't argue the data. So if your doctor or some healthcare provider says, hey man, you're on testosterone, you're going to get prostate cancer, just very nicely politically correct, say, that's not true anymore, doctor, but I know we have to be careful for the prostate itself. Right, so it's cancer, it's testosterone saturation, its incidence is actually lower for aggressive outcomes in dying from prostate cancer, and even the total incidence of prostate cancer versus men that are not on replacement exogenous testosterone. You still need to monitor PSA and technically still need a digital rectal exam, but I see a lot more because I'm studying this 24/7. Even last night, getting ready for this video, I looked up digital rectal exam by experts. Do you still need to do it when you're looking at PSAs? And some doctors are not doing it. I still feel that I'm an old-fashioned guy, that you should have a great urologist feeling the prostate. But if they don't like something, including the PSA acceleration or the digital rectal exam, your family history or just anything, your urinary changes, they're going to do a prostate MRI. It's expensive, but again, guys, squeaky wheels. Maybe $3,000 or $4,000 out of your HSA or cash if you don't have insurance. Can it differentiate what the doctor sees in a urology doctor? Is it BPH, enlargement, prostatitis, inflammatory situation versus a malignancy? And do you get that biopsy? That's no joke. Again, welcome to the world, guys. This is 2023. I'm here 24/7 for you guys to explain this. Next, after cancer for the prostate, it's disease of the prostate, prostatitis and BPH, benign prostatic hyperplasia. That I have it, right? I'm a 58-year-old guy, been on androgens 30 years. This is like, you want to keep testosterone to a down low. You want to keep your weight low because men that are leaner have just healthier life and prostate in the pelvis. Fact check it. You'll see it. Limit steroids, limit DHT type steroids, but I know we all can love primabone and masteron and all this kind of dry stuff, added DHT stuff on top of testosterone. But it's just like, is it going to affect, forget the hair, is it going to affect your prostate? I've anecdotally, with thousands of men, I've seen the changes. And I've seen young men that are steroid using guys that I love these guys, but they're 38. It's rare, but we had to bore some of these guys out with urologists because their BPH, their prostate closed down. They couldn't pee. They're 38. There's a lot of genetics on this, and it's not as, you don't see that as much as I thought I'd see it 20 years ago when I understood the history of how Dianabol came into play, because they thought with the Russians that you're going to have estrogenic steroids and issues with steroids blowing up prostates of young men. It doesn't happen like that. But not when you're in your 20s and you do steroids for a couple months or maybe 2 or 3 years. It takes decades. But literally soon enough, or overall, chronically, it's going to affect your prostate after 10, 20 years. And some men just have prostate issues because of genetics, and not to mention dietary issues with caffeine and other sorts of drugs and all these. It's very complicated. And I think there are drugs that a lot of doctors, they don't realize that you could use PD5 inhibitors like tadalafil. It's FDA cleared actually for BPH instead of some of the other BPH drugs that can make men tired, cause erectile dysfunction, and make them dizzy. So again, you can come on the app, guys. This is all I do, kind of man per man on those videos and when we talk to men in the meetings. So that closes number 3 for prostate. Number 4 is into my old school heart disease stuff. These are testosterone facts that I hit on all the time, but a lot of guys always ask, Doc, where are your ABCDs? Let's run them real quick. You see them right here. A, hemoglobin A1C, glycemic index. B is blood pressure control. C, cholesterol, coronary artery calcium score. Get that screened. If you're 30 to 40, you have any risks at all, family history, you're just not in great shape, your cholesterol is not even just perfect, maybe it's just maybe on the border, you're pre-diabetic, or your blood pressure is not perfect, why wouldn't you check a $99 or less test that's super safe, not too much radiation, no IV contrast dyes, not a CT angiogram? Why wouldn't you check it to see if you have the lining of plaque in the artery? I check it every day for men, literally all week long, on the new guys that I take selectively. And I'm amazed that guys in their 30s and 40s, we don't just see zeros. I'm like, holy crap, dude, you have plaque in the artery, but good news is you're young. You could derail that train. Again, A, B, C, D deposition, you're on testosterone. You're going to have to look at the CBC for the red cells. And don't forget, you have to look at the iron studies. You can't look at a CBC without the iron studies. So I always say the same stuff, number 4. Number 5, we're going to close on this, obstructive sleep apnea. A lot of physicians, if you Google testosterone risks, black box, you're going to see OSA. You're going to see sleep apnea. That's why I want to make this video also, because every piece I'm talking about, the doctors just may not know it, or they don't understand it, or it's not relevant, or they just don't think it's relevant to say. Testosterone causes sleep apnea. It's central nervous system sleep apnea. It's kind of an issue where you sleep great on testosterone. It goes into your brain. One of the first things men say, not steroid users, just TRT guys, man, my sleep was just phenomenal. My erections are better. I'm sleeping deeper. So when you sleep deep, you're more apt to having sleep apnea. It's something that we don't fully understand, but you could fact check this. Now, on top of that effect of the androgen effect on the central nervous system, that's the limbic autonomic nervous system. That's the non-thinking part of your brain, the animal brain. That definitely, when women do steroids, they have sleep apnea, but body hasn't changed much yet. It's just affecting the central nervous system. Fact check it. But in addition to that, when you're on testosterone and you're getting puffy and big, does it affect the hypopharyngeal region? This is the ENT stuff, right? And the pulmonary stuff, where you're getting full-on sleep apnea because you're just big and puffy and you're just gaining weight and you're getting big and puffy. But most guys, it doesn't really work that way. But sleep apnea, if you're hypoxic at night because you're not breathing like you're being transported to a mountain, that chronically every night is going to affect what? The D, the deposition, and the CBC, because it's like living on a mountain, Colorado, what is that, 4,000 feet, maybe 4 or 5, maybe higher. And it's going to have effects on the erythrocytosis and the polycythemia, the production of red blood cell. You see this? So you put all the stuff together, you got to go back to the ABCDs, and you could see why if you're super lean, you're on testosterone a great dose, you're watching deposition disease with the iron and the CBC, you may need CPAP or BiPAP. Guys, we always try to lose weight, do the best thing you can, but a lot of guys, they do the best thing, but they love the CPAP or the BiPAP. You want to work with internal medicine doctors and pulmonary doctors. Again, if you're on testosterone, guys, these are the pieces, like your fingers right on the pulse. You're on the pulse of just every single thing here, because I do this as my day job, and I thought the top 5 things that doctors are not telling you would also be a good topic, but I thought that's kind of negative. Doctors are doing the best thing they can. This is my job. I'm a testosteronologist. So these are the top 5 things that you're going to really want to pay attention to. And there's really nothing else. I got the testicles, I got the gyno, the prostate, the heart, sleep apnea, red blood cells, of course, mental health. But that's going to be the end. But if you take care of this stuff, guys, and you realize it's a lot of work and you do it right, and let me help you, come to the Anabolic Doc app where you have access to me. We have live meetings, which are really cool. We have a mailbag. I respond to it. You can get labs in North America for actually cheaper in most instances than your actually commercial labs with Custom LabCorp. And then, of course, every week I'm putting on new, cool, uncensored videos that I can't make full videos talking about the regimens that are really used. I can't really talk about medicines, and there are censored issues that the social media platforms just they have rules against it. So that's why, again, I'm not here to give bad, uncensored, like dangerous, gnarly, hey guys, come over here and get the uncensored, dangerous, gnarly information, wink, wink. No, it's just where I could let my hair down and I could talk about real medicines. I could talk about doses, but I'm never saying, hey, dude, take this. I'm saying this is how it's used. This is how I use it. This is the next revolution for how I can scale myself and help as many men as possible on the Anabolic Doc app. Thank you so much, gentlemen, for trusting me. Let's crank the comments. Thank you.